All right, let's jump right in. Today, we're talking about something that's becoming more and more critical in medicine: what happens after a patient survives cancer. Because as we get better at treating the cancer itself, we're uncovering a second serious challenge: protecting their heart from the very treatments that save them.
So, picture this. You're on rounds and you have a patient who's in remission. It's a huge win, right? A real success story. But our job doesn't stop there. We have to start asking the next big question. After everything they've been through, is their heart truly safe? And this isn't some minor sideline issue. Look at this number, 25%. For survivors of Hodgkin lymphoma who got chest radiation, a full quarter of all non-cancer deaths are from cardiovascular disease. That's a massive number. It shows you just how high the stakes really are. So let's really break down this second challenge. We're going to look at the long-term cardiac effects of our two main cancer-fighting tools, and we'll start with the big one, radiation. Okay, first up is radiation. Thoracic radiotherapy, it casts this really long shadow. The damage it causes isn't something you see right away. It's a slow burn, but it can be incredibly widespread and severe, impacting pretty much the entire heart. And when I say slow burn, I mean it. Look at this timeline. It's what makes this so tricky. Sure, you might see something like chronic pericarditis pop up 5 to 10 years out. But for most of the other big problems, cardiomyopathy, valve disease, coronary issues, we're talking 2 to 3 decades after treatment. It's a silent threat for a very, very long time. And the damage is, well, it's everywhere. Radiation is what we call a pan-cardiac toxin. It doesn't pick and choose. It hits the outer lining, the pericardium, causing pericarditis. It hits the muscle itself, the myocardium, leading to fibrosis. It messes with the valves, the conduction system, even the coronary arteries. No part of the heart is spared. And check this out. Even the coronary artery disease it causes is, well, it's different. It doesn't look like the typical plaque you're used to seeing. These lesions are usually right at the opening of the artery, the ostium. They tend to be long and smooth and way more fibrotic. That's a really key pathological clue to keep in mind. This quote from the source material just nails it. It perfectly sums up the whole problem. The damage hits all the cardiac structures, and the real trouble doesn't show up for decades. This is the core challenge we're facing with radiation cardiotoxicity. Okay, so that's radiation. But of course, that's not the whole story, is it? We've also got chemotherapy. These systemic drugs are absolute lifesavers, but they can be a double-edged sword, and they have their own unique ways of impacting the heart. Now, this slide is absolutely crucial. You have to understand the fundamental difference here. On one side, you have the older drugs, the anthracyclines like doxorubicin. The keyword here is irreversible. Their damage is permanent and it's dose-dependent. But on the other side, you've got the newer targeted therapies like trastuzumab. Their cardiotoxicity is often a reversible dysfunction. This distinction changes everything in terms of how we manage these patients. And if you want to know why we worry so much about anthracyclines, here you go. 26%. For patients hitting that cumulative dose of 550 milligrams per meter squared, the incidence of heart failure can shoot up to 26%. It's exactly why tracking every single dose is so important. With the targeted therapies, the effects are a bit more specific. You've got trastuzumab causing that LV systolic dysfunction we talked about. Then there's sunitinib, which is famous for a nasty 1-2 punch, a drop in ejection fraction, and newer worse hypertension in up to half of patients. And with bevacizumab, you also see hypertension, but the good news is it's usually reversible. So if you remember one thing about this class of chemo, make it this. The long-term damage from anthracyclines is an irreversible dilated cardiomyopathy. Once that damage is done, it's done. And that just highlights how critical prevention and early detection are. Okay, so we've got the why and the what. We know the pathophysiology. So now for the big question, what do we actually do about it? This next part is all about the practical, actionable steps, what you as a vigilant clinician need to know. So what's in our toolkit? Well, a baseline echo before starting any cardiotoxic chemo is absolutely non-negotiable. For a more sensitive early warning sign, we use global longitudinal strain, or GLS. It can spot trouble before the EF even drops. And for radiation patients, a stress echo about 5 to 10 years after they finish treatment is a really solid screening strategy.
And hey, knowing what not to do is just as important, right? When we're talking about routine screening in a survivor who feels perfectly fine, who is asymptomatic, we want to avoid these tests. Routine biomarkers, routine nuclear stress tests, or routine coronary CTs are just not recommended. We want to be careful, not create unnecessary tests and radiation exposure. Let's get really practical for a second. Take a high-risk drug like sunitinib. The protocol is actually pretty straightforward. Step 1, get a baseline LVEF and NT-proBNP. Step 2, check it again in 1 month. And step 3, keep monitoring every 3 months for as long as they're on the drug. See? It's a structured approach that helps us catch problems early. Now, this is a definition you should have in your back pocket. How do you spot that early trouble I mentioned? You're looking for a relative drop in GLS of more than 15% from their baseline. That's your definition of subclinical LV dysfunction. And when you see that, that's your trigger. That's when you pick up the phone and consult cardiology. And honestly, this might be the single most important slide of them all. For every single one of these cancer survivors, we have to be absolutely relentless about managing their traditional risk factors. Smoking, cholesterol, blood pressure. These are the basics. And in this population, they are beyond crucial. We just can't let them slide.
Whew, all right, we've covered a ton of ground, so let's boil it all down to the essentials. What are the key things you absolutely need to remember when you walk into that patient's room?
Takeaway number 1, and it is a big one. Any patient with a history of chest radiation, you have to treat their cardiovascular risk factors aggressively. It's not optional, it is essential. Their risk for coronary artery disease is already through the roof, and we have to do everything in our power to lower it.
And takeaway number 2 brings us back to that critical distinction with chemo. With targeted therapies like trastuzumab, the cardiotoxicity is often reversible. This is huge. It gives us a real window of opportunity. If we catch it early and manage it well, we can see that heart function recover. That is a really powerful and hopeful thing to tell our patients. And so we'll leave you with this question. As our cancer treatments get smarter and more effective, with new immunotherapies and targeted agents coming out all the time, this field of cardio-oncology is just going to become more and more important. The challenge for all of us is to keep up, to understand these new risks, and to figure out how we're going to protect the hearts of the next generation of survivors.